Good morning, everybody, and good afternoon to everybody on the East Coast. Thank you for attending this PrognoCIS webinar, On Track for MACRA, the Provider's Guide to the Quality Payment Program. So I'm Matt Garnice from Vismatics Marketing, and here today we have Joe and Kemp from Vismatics, and we'll get started with Joe right now to kind of take everybody through MACRA, the Quality Payment Program, and so we'll be going through that, and just the different requirements for participation, the reporting requirements, and what entails the reimbursement that you'll get for MACRA. So let me just hand it over to Joe, and we'll get started.
All right, thank you, Matt. Well, I want to say good morning to everybody, and as Matt said, what we're going to look at here primarily is the CMS aspect of the quality payment, a little bit of meaningful use, but primarily the new quality payment program. The reason for that, and as you're probably aware, the quality payment reporting is based either on Medicare eligibility or Medicaid eligibility. And as of 2011, it's been the meaningful use program for both, all providers, and they had to choose one or the other. As of 2016, however, the meaningful use side has ended for Medicare. So instead of having a stage 3 meaningful use for Medicare enrollment, there is now the quality payment program. There's two pieces under the quality payment program, which is under the umbrella that MACRA has instituted as far as basically replacing traditional Medicare. Now for Medicaid, it is business as usual. They are continuing through 2021 on the EHR incentive meaningful use program. For 2017 alone, they can continue to report under the modified stage 2, which was already relevant for last year, or they can go ahead and advance into stage 3. As regarding the meaningful use side again for Medicare, the deadline is now a couple days past, but for those who had not yet demonstrated, they were able to file for a hardship so that they would not have to apply for QPP this year. Otherwise, if the provider is not a first-time Medicare provider and they have previously attested under MU, they will now be under the quality payment program. And then again, for meaningful use, Medicaid professionals is going to continue on. Now, one significant change here for a professional who has dual eligibility, meaning they could do both Medicare and Medicaid based on their patient population and claim volume, they can now choose both programs. When it was meaningful use only, they had to choose one or the other. So a professional who did both Medicare and Medicaid chose. Now, if you are continuing in Medicaid meaningful use because you still have incentive periods left, you can continue to collect those. But if you also qualify under MIPS as a Medicare provider, you may also get a Medicare bonus. And as with always on the Medicaid side, we do encourage that you would verify at your state level if they have overridden any of the CMS requirements. Now, specifically for the quality payment program, CMS has set up an entire website for QPP, and so that's where a lot of our information is coming from. And again, that is what's replacing the meaningful use for Medicare providers under the umbrella of MACRA. And this is, instead of the traditional fee-for-service, providers will now be paid on a performance base, either the MIPS or the APM. And basically what those new acronyms are, the MIPS program stands for Merit-Based Incentive Payment System. This is basically a combination of 3 existing programs plus 1 new program that they've added in. And we'll touch on that a little bit later when we get to the actual requirements of the program. For 2017, only 3 of the programs are applicable. And the way the payment will come to you as a provider is based on a cumulative MIPS score. And that is going to be calculated by the measures that you submit under all of these different categories. We will also touch on that here at the end of the session as far as how that MIPS score is calculated. Now, the alternative to MIPS is APM, or Advanced Alternative Payment Model. Now, for 2017, honestly, the focus is under MIPS There are a handful of clients that are participating in an APM, but that did require that you register with CMS and that CMS has to approve you. So unless you've already registered and been approved for an APM, you will be under the MIPS side of things. And as previously mentioned, for meaningful use, that is going to continue as is under the EHR incentive program rules for Medicaid. So the focus again today is primarily on the MIPS because that is where most of you are falling on the Medicare side, even if you are still doing Medicaid. So for the eligibility aspect, another benefit here under quality payment compared to meaningful use as far as a Medicare provider's enrollment goes is you are now available or eligible rather, whether you are a fully credentialed physician, a mid-level, such as a PA or a nurse practitioner, as well as nurse specialists, CRNAs, even non-patient facing providers, as long as you exceed the low volume threshold. Now that low volume threshold is a two-part requirement. It is a requirement that you bill 30,000 or more, Med B allowed, and also those billables are for more than 100 Medicare B beneficiaries. Professionals who are excluded to participate are physical or occupational therapists, clinical social workers, certified midwives, as well as anybody who has enrolled with Medicare for the first time in 2017, or any clinician who fails to meet one or both of those low volume threshold criteria, and or anybody who has been approved to participate in an APM. Now it's important to note here that an ineligible provider is not the same as a provider who is eligible and refuses to participate. And I'm going to kind of revisit that again when we talk about the reporting requirements. Meaningful use, again, for Medicaid, the requirements are unchanged. So based on whatever stage they're going for, there are certain core objectives that they will have to meet. The clinicians registered for MU based on their Medicaid participation as far as the threshold of claims and patients that they treat. So with regards to verifying your MIPS participation, on the CMS QPP page, they do have this participation lookup wizard. Now, this is based on your individual NPI number, even if you're part of a group. So every clinician, to determine their level of participation as a Medicare eligible participant, will put their individual NPI into this field and click the Check Now button. And then it's going to let you know individual or group status. Individual, of course, would be any clinician whose NPI is also tied to a single tax ID, a solo practice. Your data in that case will be submitted individually for each of the categories. And then when your MIPS score is calculated for your payment adjustment, it will be based solely on your individual performance. Now, if you are eligible as part of a group, which is 2 or more clinicians who have reassigned their billing rights to a single tax ID, in that case, the payment adjustment will be based on the performance of all clinicians in the group. And the note here is even if those clinicians are not otherwise eligible individually. You may qualify both as an individual and a group, and it is your choice in that scenario if you want to report both ways and let CMS take the higher of the 2 scores. There are some additional stipulations for group reporting. So if you are going to do that, there is another reference link here that we're pointing people to. But for the most part, when you plug in your NPI, you're going to get one of several statuses. I didn't include screenshots for every status, but it's basically these 2 sections that you would see. In the upper left, we see where the eligibility at the individual level, it says that Dr. Cooper must submit data to MIPS, meaning he's eligible. And then on the lower section, we have it under the group of on the bay internal medicine as opposed to individually. And there it also says that as part of that group, Dr. Cooper is both eligible individually as well as part of the group. So these different statuses could be any combination of individual eligibility, group eligibility, both, neither. A provider may be part of multiple groups. Each of those groups may have its own designation based upon, again, how they treat Medicare patients and what your particular role is within that group. And you may also be totally exempt. In addition to that, based on where you practice, there's also special designations assigned. So for instance, if you are designated as a small practice or rural health or in a health professional shortage area, then those special designations in conjunction with your eligibility above will give you some special requirement reprieves. Specifically in the one category we're going to look at called improvement activities, they cut the requirements in half for you by doubling the points. So it is good that you go on there to the site and figure out whether you should be reporting individually or group, and if these designations apply, because that will impact the measures you choose, as well as how the data is going to be captured and reported for you. And then more importantly, or just as important, along with that, for 2017, since it is the transitional year for MIPS, they are allowing a pick your pace. So this again is a big change from meaningful use. Under MU, it was a lot more rigid, where you had specific thresholds, you had a specific number of days, and you had to report within those requirements. Well, for quality payment program, the goal and the intent is to make everything performance driven. So they're now putting all of the flexibility and choice on your shoulders as the clinician, including the first level of no participation. If you don't want to participate, it is not mandatory that you do. However, if you don't, you will receive a negative 4% payment adjustment come 2019. And this is where I want to mention again that ineligibility is not the same as no participation. If you are deemed ineligible, you're not going to get penalized with this negative adjustment. But if you are deemed eligible and you just choose not to report data, then you will receive the negative adjustment. But that is one of your choices. If you don't want to worry about capturing data, you do not have to, but you will take that hit on your Medicare money in 2019. The second option is test or minimal participation. And this will result in a neutral payment adjustment. So there will be no negative penalty and there will be no positive bonus. You will simply break even. But in this regard, all you have to do is demonstrate something. You can choose some data for at least one category for any number of days. So again, unlike MU where they legislated it had to be 90 days or it had to be 365 days, you can choose 1 day, 1 week, 90 days, however much you want. You just need to demonstrate something. And that way you won't get a negative penalty, but you also would not get the bonus. The caveat here is based on which category you choose to submit data under. As we're going to see here in a little bit, there's 3 categories of data. If you submit it out of the base category, even though it says at least 1 is the requirement, base is 1 unit of 5 individual measures, so you would have to report all 5. However, if you choose quality or improvement activities, you only have to choose 1 of those. And again, either situation can be for any number of days, any number of patients. Partial participation then, which is probably where the majority is going to fall, will result either in a neutral or a small positive adjustment. And this does require at least 90 days worth of data. Therefore, your data would have to have begun by yesterday. And again, this time, though, it is all 3 categories. You would have to submit at least the 5 base measures, a minimum of 6 quality measures, and then under IA, it's not a number of measures, but a number of points. And we're going to get into all of that as far as how you determine what the values are. That would be your bare minimum for 90 days, and you would get some sort of a positive bonus in 2019. Full participation is an entire year of data again, across all categories. So partial and full. The only difference really is the amount of time, whether it's 90 days or an entire year, but you are choosing data across every category and reaching at least the minimum requirements. And when I speak of minimum requirements, that means anything beyond that could qualify you for bonus. And that's how that MIPS score can get higher because it's all performance driven. So even though there's no thresholds here legislated like under MU, you can kind of self-impose certain requirements on yourself. And even though it says minimum of 6 quality measures, you might want to submit 9 or 10. That way you get all those additional bonus points. So now we're going to look at the actual reporting and the measures. Again, for the MIPS under quality payment, there are 4 subcategories. For 2017, the cost category is not applicable, so we're not discussing that today. The other 3 categories, quality is what used to be known as PQRS, as an independent legacy program. That is no more as far as being an individual program, but it has been absorbed into MIPS as the quality category. The second category, improvement activities, is brand new under the quality payment program. So that is nothing that was there before. And the third category, advancing care information, is the MIPS equivalent of MU. So even though you're not under MU specifically as an individual program, the core objectives are absorbed into MIPS. So you will still be doing an attestation. Excuse me. You do get a lot of choice, though, in all of these categories. You get to choose what's relevant to your practice. So that is also a fundamental difference over the MU, where whether they mattered in your specialty or not, you had to report them. You get a little more flexibility now by choosing what is relevant to the scope of your clinic. Now, with regards to the quality category only, the data submission method is important. The way the data is submitted to CMS is also going to determine what measures you select, because there are different measures for each of these methods of reporting. They're also different for individual versus group. For instance, the ones that we support within PrognoCIS would be either EHR-based or claim-based. And basically the difference there is clinically, you're still gathering the appropriate data for the measures you choose, but if you're going to have us submit the data on your behalf, it doesn't require specific charge codes on the claim. If you're going to let CMS tally your data off of the claims you submit, then you have to be sure that your claims have an appropriate quality data code present. And that is what would trigger CMS to process the logic for you. The other categories, your choices are either going to be an attestation or having PrognoCIS submitted on your behalf. So the attestation is the only option you ever had under meaningful use, and that will continue to be. But then we've also now got the ability of submitting the data for you as an option. So now we're going to look at the different measures by category. And for each of these, the list is on the QPP website, and we're giving you the score or the percentage of the overall MIPS score that comes from that category. So you see here, quality is 60%. So this is the highest impact as far as where you want to do your best performance is going to be across these measures. So you definitely want to select measures that best fit your practice. Some measure definitions change from one calendar year to another. So you may be used to measures on your existing system that may or may not be the same this year. So it is important to note that sometimes the definitions change because the diagnoses or the CPT codes may also change. Now you do have to choose up to 6 measures as a bare minimum, unless you're opting for that test participation, where you just want to break even. But if you're doing partial or full, whether it's 90 days or 365, it's a minimum of 6 measures. It does have to be all 6 chosen from the same data submission method. So whether you choose the claim-based or the EHR-based, which has a different set of measures for each. All 6 will come from the same category. One of them must be defined by CMS as an outcome measure, which is a type that they define. And if there is no outcome measure relevant to your specialty, then you must choose one that is defined as a high priority. So I'm going to show you how you can make those determinations by looking at the measures. So for the claim-based category, there's a total of 74. 26 of these, at least within PrognoCIS, were automatically carried forward from the former PQRS program. And for the EHR base, there's a total of 53, 22 of which were formerly part of meaningful use. Now, when you go to the QPP website to look at these measures, they do give you the ability of filtering on specific criteria to help you filter through. If you notice here in the default screen capture, there's a showing of 271 measures. It's right above my little number 2 bubble there. This is the total of quality measures. But then if you filter it, there where you see the number 1, high priority, yes or no. Data submission, do you want EHR? Do you want claim? Specialty, because you might want to, instead of scrolling through 271 measures, look at only the ones relevant to your specialty. So you can plug and play here the different combination of filters. And then when the measures are available to you there on that screen, they're expandable by clicking on the hyperlink. And this is how you're going to determine not only the definition of the measure as far as what you need to do clinically, but also the measure type and its high priority status. So I got a couple of examples here where a measure type may be process, it may be outcome. There's a lot of different measure types, structure, functional, etc. One of the ones you choose has to be outcome. The other 5 can be anything you want. And if there is no outcome measure, notice here then on the bigger one in the background, my process measure is considered a high priority yes, so that one would also qualify. So if you don't treat asthma patients, so you cannot choose this outcome measure, but maybe you do treat otitis issues. Maybe you're in a family practice, you just don't happen to get into asthma, so you don't want to report that one, then you could choose the other one because high priority is yes. So it's one or the other there as far as one of the 6 that you choose. Going to the improvement activities then, which is the new category under MIPS that we did not have before. This is 15% of your overall MIPS score. Improvement activities are not numerator-denominator values, which is what we are accustomed to primarily under MU and what these quality measures are, where you have to demonstrate X number of patients and have all of these different quality markers. Improvement activities are going to be yes/no attestations. So these are processes or procedures that you put in place. They do not require data be captured in EHR. At the end of the year, you're simply going to attest, yes, you did it. And because it doesn't require data to be captured in the EHR, you are required to maintain documentation for up to 6 years. So that if you ever got audited, you'd be able to prove that, whether it's an in-service log, sign-in sheets, policy and procedure manual, all depends on the activities you choose. Now, unlike quality, where you have to choose a minimum number of measures, for the improvement activity, it's a number of points. And each activity is worth a number of points based on how CMS has weighted it. So they have 2 categories. They have medium weight activities. Each one is worth 10. And they have high weight. Each one is worth 20. And this is the category that can be cut in half if you qualify for one of those special conditions up above, such as a rural health practice. You would only have to report 20 points instead of 40. These activities there's a total of 92, and they are categorized through 9 different categories, such as patient safety, care planning, different things of that nature to help you in determining the activities you want to go with. Now, out of those 92, Although it does not mandate you store the data in an EHR, there are 18 of them designated as ACI related, which can earn you bonus points under the ACI category, which we'll look at next, if you save the data in EHR. So it's kind of a two-part selection process for you when you're deciding on your improvement activities. If you don't care about bonus points, then you can just choose yes/no processes that don't involve EHR, implement those processes, report them, you're good to go. But if while getting these 40 points, which is required under the MIPS to get your basics 15% for this category, but you also would like bonus points, then you want to choose from the 18 specific ones that do require data be stored in EHR. So when you go out to the website again at CMS, you can filter here by the subcategory or the weighting to see which measures you want or which activities you want to report. And as you see in the lower example here outlined in green, it's either going to say medium or high. And the medium again would be worth 10 points, high would be worth 20. And this is a list of the 18 that cross over as an ACI bonus. The third category then is the advancing care information, or ACI. This counts for 25% of your overall score. This is the QPP MIPS equivalent of meaningful use stage 3. These measures require certification, of which PrognoCIS is certified for the current requirements. And these measures are classified in 3 subcategories. So this is where the math starts to get a little fun when you're worrying about how they get that score for you, as you'll see when we get further into the presentation here. It's a single category under MIPS called ACI worth 25% of the score. But to get that 25% of your score, it is divided into 3 subcategories: base, performance, and bonus. There are 5 base measures, all of which are mandatory in order to get any credit at all for this category. So this is the one area where you do not have a choice. In order to get your bare 25% here, you must report at least the 5 base measures. Then there's 9 performance measures, which can earn you additional performance points up to 90. And again, here there are no predefined thresholds. You simply need to report at least 1 patient to score at least 1 point for that measure. But as you'll see when we get into our scoring examples, the more data you submit, the higher your score is going to be. So it does behoove you to worry about quantity, even though it is not determined how much to report. And that is because there are these national benchmarks that CMS has predefined that breaks your performance percentages into categories worth 1 to 10 points each. Then the third category of bonus, again, is optional. And you can get bonus points in 2 ways. One of them is 3 of your ACI measures are counted not only as an ACI measure, but also as a bonus. These are your public health reporting, such as immunization registry, syndromic surveillance, things like that. That is one way to get bonus points. The second way is, as we mentioned up above, 18 improvement activities that are defined as ACI related will also qualify to get you bonus points. So this time it's a little different on the CMS page when you go out to look at the measures. They don't have filtering because there's only 2 categories. The one category, which is current for 2015 certification, is the one outlined here in blue, the advancing care information. And then the ones that on the other side, which we are not supporting, are for the previous certification version for EHRs who may not have gotten recertified yet. And out of these 15 required measures, this table is showing you how they're classified as far as base and performance, performance and bonus, or bonus only. And this again is kind of where you can see where your score is going to greatly fluctuate. because you get a minimum of 50 points by reporting the 5 base. But out of those 5 base measures, 3 of them also count as performance. So not only do you get the 50 base points, but you right away qualify for an additional 30 performance points. It could be less than 30 though, because a performance measure is worth a maximum of 10, but based on the data you submit, it may be less than 10. So there's then an additional 5 performance measures that are strictly performance driven, completely optional. The performance/bonus, where again you would get your 10 performance points or up to 10, but also qualify for the bonus. And then the final ones are bonus only. So the only ones you need a mandate here again are the base measures. But we encourage strongly you also do the performance measures so you get that higher score. So those are the 3 categories of measures and how you can locate their definitions on CMS. And incidentally, we also have the ability in PrognoCIS to locate those measures as well. But now we're going to get into the weightage and scoring so that you can see how at the end of the year, CMS says you're worth this number of points. This is the payment adjustment you get. The weights assigned to each category are numerically based on a maximum of 100 points. Each of the categories has a percentage of weight to determine how many of those 100 points you get for each of those categories. And then the overall MIPS score is going to be those 3 categories' individual points added together to equal a composite number between 1 and 100. So what we're going to show you in the next few slides is random example of partial participation. You can always plug in your own numbers after the fact to see how the points will change. But for instance, here on the quality category, which is a 60% weight of the, meaning is worth 60 points total, there are performance benchmarks, which CMS has defined for each individual measure. Now, if you recall from earlier under quality, there's 74 claim-based measures, 53 EHR-based. Each one of those measures has a different benchmark. So this is just a random example I'm showing in the PowerPoint. These numbers are not the same for every measure. The benchmarks were created by CMS based on data submitted in 2015 PQRS. That's how they derived at all of these percentiles. And they've broken them into these deciles from 3 up to 10 points. So when they get your measures, however you're doing it, whether it's claim-based submission or EHR-based, when they plug your data into their algorithms, they're going to compare them into all these different percentiles based on the message or the measure and come up with a number of points for you for each measure. So for instance, in example 1, I'm given the worst case scenario, you report poorly. So you only get the minimum of 3 because whatever measure it is, you only got a 5.25% performance on it. Whereas on the bottom is best case scenario, where you're going to get the full 10 points because you submitted a lot of good quality data. So taking that logic and just plugging in numbers here randomly so that you can visually see a score, we are counting the 6 minimum required measures here and just giving you random number of points based on your performance. And then we've also chosen a 7th measure to give you a bonus. So if these were your points when CMS got your data, you're going to end up with 90 points for your quality category because each of those measures was worth up to a possible 10 points plus the bonus. Just kind of store that in short-term memory because we're going to bring it all together to get your final score here in a minute. But for the quality category, you're getting 90 points. Then moving to the improvement activities, which is worth 15% based on submitting at least 40 points. So here it's not the number of measures, it's the points, which again is based on the activity weight of the measures you choose. So your options here, as you're making your choice through those different 9 categories of 92 activities. On the upper example, we're showing a selection of 3 activities to equal 40 points. 2 of them are medium, so that's 10 points each equals 20. The third one is a high, which is 20, so there's your 40 points. The lower example, there's only 2 activities being reported because they're both high, which equals 40. You also could choose 4 medium, which is 10 each times 4 would equal 40. You can do more than 40 if you want, but the minimum requirement is the 40 points in order to get that full 15%. So in this example, we ended up with 100 points because we did submit the required 40. And CMS has given you this calculation. In order to get your IA score, you take the total number of points divided by 40 and take it times 100. So 40 divided by 40 times 100 equals your 100. Now remember, 18 of these also count towards ACI bonus, which we'll see in the next category. So you also could get not only these 40 points, but additional bonus points based on the activities you chose. And then for the advancing care category, which is worth 25%, this 25% weightage is going to be given to you based across the 3 subcategories cumulative score. And the 3 subcategories can actually equal 155 maximum. Now, if you get anything between 101 and 155, you get 100% score here. CMS will scale it back to 100, meaning you get the full 25%. But this is where you can start to see the benefit of more data can give you a higher score. So if you do the base, again, in order to get any counts at all, you must do the 5 base measures. Otherwise, you get 0 for ACI. The one exception here, again, would be if you are doing the test or minimal participation, you do not need to choose ACI. You may have chosen only quality or only IA, so you wouldn't worry about this. But if you're going for minimal, partial or full participation, you will need to make sure you do at least those 5 base to get those 50. And then you can have up to maximum 90 in performance, up to a maximum of 15 bonus. That's where you get your maximum 155 possible points. And the way those bonus points are broken out, the 5 points is coming from your public health reporting measures, which are also performance measures. Now, there's 3 of them that qualify. There's the immunization registry, syndromic surveillance registry, and special registry. Whether you do 1, 2, or all 3, you only get 5 points bonus. And then if you choose any of those 18 improvement activities, you get 10 more bonus points. So taking those into account, you report all 5, so you get 50 points for that subcategory. The performance measures now are very similar to what we saw above for quality. There's benchmarks, but these benchmarks are different. These benchmarks now are based in increments of 10. Looking at your numerator, denominator, again, you can kind of see here by plugging in your own numbers where the more data you submit, the better your score is. The example I'm given, we got a numerator of 90 and a denominator of 100. That gives you a performance rate of 90. Plug it into their benchmark, that equals 9%. 1% per point, you get 9 points. So if this measure, you only submitted 50, then obviously you only get 5 points. So that's why it is important that you try to submit as much data as you can. And then in the case of the public health reporting, such as immunization registry, you're either going to get 10 points or nothing. If you have the immunization registry active as a performance measure, you automatically get 10. You also get 5 bonus. And that is what we're doing now. So we're giving you the 5 bonus in this example because of having public health reporting turned on. If we had also chosen improvement activities that were one of those 18, you would get an additional 10. But for our example, we're only giving you 5 bonus. So taking those 3 together now, your overall ACI score, your base of 50, your performance of 90, your bonus of 5, gives you a total ACI 145. CMS scales it down to 100, so you're getting the full 25% in this category. So now taking all 3 of those primary category scores, We had our 90 points for quality. Now we're taking it times the 60% weight to translate into a final number of MIPS points of 54. IA and ACI, we got the 100% in both of those, so we get the 15 points for IA, the 25 points for ACI. That gives us a final MIPS total of 94. And again, these numbers are just random. You can plug in all different numbers up above and end up with a different score here. But now when you plug that into the CMS table, you'll realize where you're going to fall as far as the adjustment. Whether based on this score here of 94 points, you qualify for exceptional performance bonus as well as a positive adjustment, so you'll probably get the maximum 4% positive. Whereas if you fell in lower there, but 4 and 69 points, you don't qualify for exceptional bonus. Your positive adjustment is going to be smaller. Now, just quickly here, the alternative to MIPS is APM. For those who registered and were approved by CMS, their requirements are a little different. They're not measure-based, so there's no choosing of measures like we saw up above, but each payment model has its own requirements as far as what the documentation entails. There are also clinical quality measures involved, so that is the one exception. They do have to report clinical quality measures in addition to whatever the APM requirements are. And then for meaningful use Medicaid, nothing has really changed there. Again, there's core objectives based on whether you're going to stay with modified stage 2 this year or go ahead and advance into stage 3. And this continues through 2021 until you've received at least 6 incentive bonuses. And this also does involve clinical quality measures in addition to the core objectives. So modified stage 2 has 10 core objectives, all of them being mandatory unless you qualify for exemption. Stage 3 has 8. Now that number is a little misleading because each measure has multiple components. So you may have measure 4 ABC. So it actually counts as 3 measurements under one measure. And then at the end here, we just have some appendices thrown in summarizing what the requirements are for each category. A getting started checklist about determining your eligibility, deciding on your level of participation, and then choosing measures accordingly. If you're interested in group reporting, they have some different information as to their payment adjustment methodology. And then the separate website for your electronic clinical quality measures. And then this last appendix is the setup screen within PrognoCIS, as well as the report. So within PrognoCIS, once you have set up, whether it's the quality payment program or meaningful use, we have category and year sensitive reports because everything is based on the provider and the reporting year and the measures chosen for that reporting year. So in all of our drop downs, you'll be able to categorize it by year and program and then get detail or cumulative reports. So that's the extent that I have as far as the quality payment and meaningful use program background. So I'm going to turn it back over to Matt now.
All right, thanks a lot, Joe. That was very, very informative. So we did get a few questions during your time, but we want to wait until the end if we have time to take some of those questions. And so we have Kemp up next with the product demo, just to kind of, show you through our product. It is a MACRA Certified EHR product, and so he'll take you through how the product works and how it enables you to meet your MACRA reporting requirements. Ken?
Very good. Thank you. Thank you, Matt. Joe, thanks so much. Very nice. And so as you've seen, there is obviously a lot to keep track of. So I think the philosophy here from Bizmatic's PrognoCIS is to just really make it so that you can get through your day and really take care of the patients, because that's what it's all about. You don't want to have these things distracting too much from that. So with that in mind, just wanted to quickly kind of just show that, you really can be kept on target still and still give good patient care at the same time. And just showing just a few examples of that. So for those of you who've never seen PrognoCIS, it's really designed to just give you the info you need to focus on at any particular time. And so Joe was showing some of the setup screens. So a lot of these measures are already going to be set up in the background so that whatever track you're going through, those things can be done just by virtue of the fact of seeing the patient and doing the documentation. Here, for example, I'm just at a dashboard. I can just quickly see what we've got going on here today in our office. So if we have patients scheduled, we can see who those patients are, the reason they're coming in. And of course, as we're completing those patients and we've signed off, it's going to say complete. And so an EMR, of course, needs to keep track of all that information, needs to be able to keep you in communication with the other medical entities, being able to share that information. So if I come in on a patient, for example, I'm looking at very nice data summarized quickly that I can see what's been going on. And depending on your specialty, for example, this screen might be totally different. If I was a pain management doctor, if I was an OB, and it was a lady who is expecting, I might be seeing prenatal flow sheets, etc. So as I come in, as staff are taking things like vitals, I can see those things quickly. I can trend the data. And of course, this is no longer a measure for this year, but in previous, as we're taking vitals, it was automatically taking care of those measures. PrognoCIS is designed to just be very fluid. You'll see I've got workflow arrows that just let me quickly go through. And here, this patient last time I can see was coming in regarding diabetes, and we were discussing diabetes. So anything that you see in yellow means it's been copied over from previous. So I could elaborate on this more today, if maybe the patient is taking, blood sugar readings, and they've been taking it, maybe twice a day, and I can put in what those values are, etc. However, if they're bringing up anything new today, we can also bring that in. So if we're saying, okay, patients also got hypertension, also complaining of maybe, stepped off the curb funny in the parking lot, we can get these things nicely documented. And it keeps things very fluid with whether you want to use the templates or whether you would just simply prefer to jot some notes or do voice recognition. You can do that very easily using the notes areas. So if I am using a template and I have everything very much the way I like it with all of my defaults, you'll see I can quickly just tap at the top, and then I can come through here and mark the specific things that are different about this particular case and move on. Same thing if I choose my other complaint, I can see I've got a nice template. I could either dictate, type notes, or again, I can use this quickly, make any changes. And then you'll see the workflows just let me move on through. So you may have all of these measures that you're needing to keep track of, but notice that this just kind of keeps you on target. You're focused on the patient, and with as minimum of distraction, you'll be able to meet those things. You also can see very quickly for a follow-up, as in this case, things that are really important that I might want carried forward for me are already here. Like, for example, the review of systems from last time. I can see any of those areas where there's a problem. He had a problem with respiratory-wise because he was complaining of a cough. Well, today maybe he says he's got some wheezing going on. We update that, and I can just keep moving right nicely through my arrows. So flexible, easy to work with, and I can override if I need to. If I need a more detailed physical exam, I can quickly get to those things and make any of those changes as needed. And the whole time, of course, we're getting very good, clear documentation. And this information can be shared with other physicians very easily as well. Now, if I'm suddenly needing to message someone, you'll see up here, I don't need to be distracted. I've got a nice button here where I can quickly compose a message. And it can be, internally, it could be via the patient portal. So if I want to communicate with the patients, I can. And I can easily choose from our action lists of what needs to be done. You know, maybe we need to call a patient, needs to be done within the next day regarding their meds. So we can make sure that all of these things that might pertain to the measures are also being addressed, and all of this info nicely there. Now, when I get to things like my assessment, for example, the system can help me to choose ICD codes. So you'll see I've got my ICD-10 right here. I've got, for the hypertension, he came in today for the ankle sprain. So the system is thinking this might be what the issues are, but I can always jump into my preferreds, or I can do a very detailed drill down if I need to. And one of the measures, of course, being education. So if the patient says, hey, tell me more about hypertension, the little EDU button here pops me right in via Medline Plus. It looks up the appropriate education item from the ICD, and I can be more specific, drill down, or I can just say, how about if I give this to you in the portal, or would you rather I print it or email it to you? So just by doing things like this, I'm addressing these measures. Also, very nicely, I can see down here my prescription. So RX allows me via the SureScript network to quickly give medications that might be necessary. And I can see all my preferred meds, quickly choose those that have all of my favorite instructions, and I can send these right to the pharmacy right from here just by hitting ERX. But it'll let me know if there's anything important in terms of a drug to allergy, drug to disease, and I can take those corrective measures if I need to. I also can read in patients' medication history based on their visits to other providers, just with this little button here. So really make sure that you can't, get too far down the wrong path on anything, and catches things really quickly. Same thing for my order sheet. I can, order anything very quickly, whether it be a lab that needs to be done, or as I choose those items, it brings it over. If I need to do a radiology, maybe for his ankle, I can quickly choose those things. And we have very nice interfaces to all the different types of facilities, or can be done if we don't already have an interface in place. And of course, billing wise, we can get our E&M code. If we want to choose a specific code, we can, or we can use the E&M calculator to quickly help us for what kind of a billing code might be appropriate. The system keeps track of what we've done here under HPI, review systems, and physical. And so I could just make a subjective decision as to the complexity. And it tells me, okay, you could do a 99213, tells me what I'm missing to get to the next level. If I just reviewed the past medical, family, and social, and it highlights, and I can go ahead and choose it, or I could override it, or maybe we spent more time, and so on. And of course, when I get to the stage where I'm finished, the system gives me a nice summary of what we've done. I did forget to indicate follow-up, so I could say, oh yeah, that's right, he needs to come back in 4 days, and the reason why. So this will make sure that my front desk gets the message, and they will get that appointment made. And I can say, okay, I'm done with this. Just mark the encounter complete. And here it takes care of the communication automatically. So as we saw, the measures that need you to be able to send secure information, all I have to do is just simply tap yes to send to Dr. Cooper the information about this patient, what was discussed today, or even their medical record if I wanted to. Provide the clinical summary. So if I want to provide the clinical summary, I'll just say yes here, because it'll let me quickly decide if I want to either print it, or maybe I would just rather send it to the patient portal. They can get it right there. And then with that, I might say, okay, I'm done. Any other meaningful use measures I missed, the system will let me know those. And with that, I'm done with the patient, and I come back to my home page, and we can see Mr. James White is complete. So when this is set up, according to what Joe was telling you with the different measures that you have selected, we want to try to minimize it as much as possible, that distraction, so that these things are being taken care of for you. And so that, at the appropriate time, you're able to run your reports So we have a whole series of different reports regarding meaningful use, or to be able to submit that data. And we also have very nice tools. Now, I realize this is slightly an older version here, but we have very nice dashboards that'll let you see whether you're keeping up with those measures or not. This here, of course, is meaningful use stage 2, but we have very similar dashboard for the MIPS MACRA, where you can make sure all of the areas that should be addressed, if they're not in the green zone, for example, we can make sure that those are taking place for each provider in the practice. So with that, I will wrap it up here, and just wanted you to see how we want to stay on the practical side, get those measures done, but also not detract you from giving excellent patient care. And so just a small view of PrognoCIS at the same time. And with that, Matt, I will turn it back over to you.
Okay, well, thanks a lot, Kemp. That does bring us to the conclusion of today's webinar. I don't think that we'll have quite enough time to answer all the questions that we received from you guys, but please feel free to visit our website, PrognoCIS.com. You can visit our MACRA page, PrognoCIS.com/MACRA, and you can also go to the Contact Us page to contact us with any questions you may have. So with that, I'd like to thank you all again for attending, and I'll close today's webinar, and everybody have a nice afternoon. Thanks, everyone. Bye-bye.